So I'm going to catch up to where we were just a second ago. I should share with you that this morning we were in the operating room together, Dr. Kikawa and I, and we were operating on a patient with thyroid disease together, where I was doing the muscles and he was doing the lids. So it's not uncommon for us to do stuff like that. It was his operating room time. I made a guest appearance because I'm there and we're together all the time, and we do that back and forth. That is really easy when you're in a center working with someone who is so excellent at what he does. So I do the muscles, and you've seen all these pictures of the muscles not being normal. Well, if they're not normal, how do they move the eyes normally? And why does this happen in the first place? Well, we have all this infiltration of the immune materials from the body into the extraocular muscles, and they are now making the eye get big and thick. And so that's why we get all these large muscles. Now, if you are squeamish, don't look, okay? Because this is an eye that's been removed, and there you can see the fusiform shape of the muscle that I showed you on CAT scan. Okay, you can look again. So you can imagine not only does that muscle get big and it doesn't want to move, but eventually the inflammatory cells change the muscle from elastic tissue to scar tissue, which becomes rope-like. So you saw Dr. Cower showing you the muscle going up. It's like a dog on a leash. It gets stuck, rather than having an elastic band that can stretch. And that's one of the things that happens. So you have these limitations, and then the eye gets stuck, and that becomes a problem. So you get all these extraocular motility problems, and depending upon how you look at it, 30 to 50% of people will develop some sort of eye movement problem. That doesn't mean something has to be done. That just means even little stuff. We call any misalignment of the eyes strabismus. And there's an order to the muscles in strabismus that get involved, typically the inferior, then the medial, then the superior, the lateral, and the oblique. So there are 6 muscles, one on top of the eye, one on bottom of the eye, superior and inferior, one towards the nose, medial, one towards the outer wall, lateral, and then ones that come in on funny angles, they're oblique, and they spin the eye. So up and down, side to side, and spin. Why is it this order? We have some theories, but nobody really knows. And I was taught a long, long time ago that the order of the muscles is IMSLO, or I'm slow. Now, I don't know if they were teaching me that for some reason, but so that's the general order of it, and that's how I teach the young doctors that you'll see in our center, the residents and the fellows and medical students and endocrinologists and doctors from other countries that come to learn from what we're doing. We teach them that as well. So what do? We have to do a really good exam. We're looking at all these things to quantify how well your eyes move. We have a physical therapist for the eyes that does measurements, who's a really integral part of our team. And when nothing's going well and you're getting double vision and it's not time to operate, we'll use a prism. And I'm not going to spend too much time talking about it. Suffice to say, if you remember back in school how prisms make rainbows of light, well, they shift light. And so what we do is we leave your eye where it is, we put a prism, and it shifts the object in front of your eye. Surgery moves your eye. A prism moves the world. So that's how a prism works. And we have stick-on ones that we can stick on right on your glasses, temporarily use. They are not the happiness makers. They don't really fix everything, because in thyroid disease, when you look down, for example, remember that I went down okay, and when I went to go up, it got stuck? Well, you can imagine the amount of misalignment varies depending upon where you're looking then. But a prism doesn't vary. So you got this non-varying solution to a problem that's always different everywhere you look. So you get a spot or two that looks pretty good, or if the deviation's small, it looks pretty good, but it won't look good for everywhere. We talked about Botox just a little bit, and it usually shocks people that we talk about Botox. And the first thing they say to me, or Dr. Kikawa is, Botox, do we get a little bit up here and here? Well, what a waste to just put it in the eyes. Can't use it everywhere else. But I can tell you this, the Botox study that you heard Dr. Kikawa talk about would never have been done if we weren't standing in the room together. He's hearing me talk about Botox, I'm hearing him talk about decompression. That is only because we're all there together. And otherwise, it's not going to be thought of that way. So what we've done is we've looked at it in the clinic using Botox to inject to see what happens. Can we actually make a difference? And we presented this work looking at it. What we showed was that approximately a third of the people, we were able to avoid surgery. That's cheating, because we don't offer it to everybody. We're trying to offer it to the people who have the highest chance that it will make the biggest difference. And so the smaller the amount that we have to get your eye to shift, the better Botox is. And sometimes we can use it after surgery because we got you close, but we needed just a little more, and Botox can get that. So we're careful who we pick to use the Botox on. But what we also see is that we actually, if you look at this, you actually stop some people from getting worse who are in the middle of the disease. So their eyes starting to go down and the disease is really bad, and we hit it with Botox and it stops from getting worse. Well, I'd much rather operate on a small deviation than a big one. So stopping from getting worse is a good thing as well. So intervention earlier in the disease makes sense if you can. Now, again, if you're squeamish, you're going to want to look away in just a moment. But the doctors, national television show, just had Dr. Kikawa on looking at orbital decompression because they wanted to show what he did as the best, asked me about Botox.
Help us talk about how Botox may be a treatment option. It's pediatric ophthalmologist Dr. David Granet. Welcome. Thanks for joining us. Hi, guys. So, this is a very important issue to address. How does Botox work as a treatment
in real life is
essentially
not that
Botox
engaging.
interferes with the way
Just
the
saying,
nerve
just
runs to
saying.
the muscle of the eye. That's how you get rid of wrinkles, because the muscles relax. The same thing happens in the eye muscle. The muscle relax, so we inject the overacting or stronger muscle to make it relax, and then the eye will move in its position in the orbit to straighten out, just the way you described in how eyes should work.
That's me
It's been used
doing
in children,
Botox live.
specifically in kids who have very crossed eyes. In other words, when they're born, their eyes are just so overtly crossed that it's very obvious. And Dr. Shears was right. This is a big deal for us to get early. Those kids,
So we do this
have
in the
an option
office.
using Botox.
We take a
There's
small
4%
needle,
doctors
some
in
of
the
you have
United
this
States
done,
use that.
and we put it in right into the muscle in the office, and we're able to inject it, and you go home. So it's not always quite that easy. Sometimes a little bit uncomfortable, but it really does work. And it's kind of a cool option to have available. So the idea that we have another alternative is a big one, and valuable to have in a center when you can do it. We looked at the change in intraocular pressure when we do Botox, and we looked at the change in intraocular pressure when we do eye muscle surgery, because there is some evidence that thyroid disease may be related to an elevation in pressure or glaucoma. And we have several patients that have come to us that have been scheduled for glaucoma surgery that we've been able to stop from having an operation by doing eye muscle surgery or orbital decompression. People who've been scheduled for glaucoma surgery, we've been able to stop from having glaucoma surgery by doing eye muscle surgery or orbital decompression or both. That's a big deal. You want to be at a center where people get all this. So we went and talked to the glaucoma people, and we said, well, we called them up if they weren't our patients. We said, well, hang on, we have a different, let us try something first. So it becomes very important to think about careful planning. And careful planning means that you don't want to build a house and put a telephone pole in the driveway, right? So we want to think it all through. When we go to the operating room, we have incredibly detailed preoperative sheets that we put together. One of my colleagues said this looks like the Da Vinci Code when you put it together. So this is all the details that we have in planning surgery. It is an individual plan. You can't just say I do the same thing on everybody. That would make me nervous. And so we're going to move the muscles in order to try and restore the most greatest function we can. What you heard from Dr. Kikawa was really important from a philosophical standpoint. We're not saying that you're functioning okay and we're going to leave you alone. We know the depression and anxiety that occurs from the change in your appearance. We know some of that has to do with your function. If you set the bar low enough and you just say you're getting by, then you stop. But if you say we want to get you back to as normal as we can, then you keep going. And you say, what can we do better? How can we do it better? And you develop techniques for that. And that's what you heard Dr. Kikawa talking about. He didn't want to live with the old-fashioned style of doing this. He wanted to get people to look like themselves. And if you saw those pictures, it's astonishing. And I can tell you when we show those the before pictures to people who are done, they cry. We get a lot of crying in the office. They cry because they can't believe how bad it was. They actually don't want to look most of the time. So we go to the operating room and we're trying to get people, at the very least, the standard is you want to be able to look straight ahead and not have double vision. And if you're lucky, you want to be able to look down a little bit and not get double vision. Well, I don't like that very much. I want you to have a window of vision that allows you to function on an average day doing average things without getting double vision. No, most people will not walk around and do this. Hi, how you doing? I'm not going to look at everybody on the side like this. I'm going to turn my head. About 10 to 15 degrees, and then we turn our head. So if I can get a window 10 to 15 degrees on an average day doing average things, you'll function without double vision. If I just aim for straight ahead, I will only get straight ahead. But if I aim for this window, you'll do better. Now, maybe driving a car and you're looking over your shoulder to back up the car, maybe you're going to have some double vision. Maybe you're an electrician and you have to change a light bulb or do, okay, there will be extremes. We don't hit home runs every time. But I'm telling you, if you don't try to win, you can't win. And we're trying to get you back to full and normal function if we can. So we wait until you stabilize to do the surgery. We usually have to do weakening procedures. These muscles are tight, and sometimes they're so big and fat and tight, the eye is straight and held there by the orbital walls. And then when Dr. Kikawa makes more space, finally it can move. What it's been trying to do all along. Only the squeezing of the walls kept it straight. So sometimes you move a little bit after orbital surgery. It's why I don't go first. It's why if I went first and then Dr. Kikawa went, it wouldn't make sense. So the order matters of what order we go in. And you heard that he has to be prepared for my muscle surgery because these tethered tight muscles, when I release them, the eyeball comes forward. So he has to take that into account. And I'm going to show you in a minute how the surgery I do affects the eyelids, why he has to wait sometimes. So if we're not careful, then we mess up. I used adjustable sutures, and we're going to talk about that in just a second. So there are all these guidelines that we use to try and give you the biggest window possible. And we've presented most of our data and published it when we can. We've looked at these different patterns of the eye muscles because we have to be dispassionate in our evaluation of our own work. If we mess up, we got to get better. We got to know it. We got to look at it and evaluate it. And I can tell you, every patient I operate on, guess who also sees them? All right? I do have a little ego. I want my patients to look good when he's looking at them in addition to scoring with them. I got my colleagues, I got my patients I want to make happy. Everybody's watching me. Medical students, residents, fellows, they're all watching. They want to see what Granet's going to do. So I got to come through. I mean, we have so many people we want to come through first for the patient and then all these professional things. We have to look at our work and get better. It is our job, our responsibility to continue to get better. We know that if we operate on you, on your eye muscles that are pulling tight on your eye, your prescription may change. And so we looked at that data. Half of people have a significant change in their nearsightedness or farsightedness. 1/3 have a change in their astigmatism. It's a big deal. So your glasses may change. All right, at least we know that now. So if you come to our OR, you're going to see stuff like this. We have all this checklist to make sure everything goes perfectly. We have instruments that we have designed and built just for thyroid disease, because the tissue in thyroid disease is different. So I have instruments that we have designed specially that I use to teach, so you can see this. We have special hooks and other things we use to work on these muscles. That's one of our ORs. And perhaps the most important thing, that's our music player. We let patients tell us what they hate, but they can't pick the music that they're going to listen to. I got to pick what I listen to. But if you hate something, I won't play it, you know? I mean, if you tell me, and everybody always says, I hate rap. I don't play rap. You don't have to worry about that. We do a fine-tuning surgery called adjustable sutures. At the end of the surgery, instead of tying a permanent knot to hold the muscle, we put a slip knot there. I can slide the muscle a little bit. A week later, I give you a chance for the swelling to go down, to see what your brain and your body does, and then we can adjust it. We published, along with my colleague Shira Robbins, we published a multi-centered study from 5 different places around the country where we combined all of our data and looked at it, and we showed how successful it is. Overall, 90% of my patients I don't have to touch. The sutures dissolve, they go home, they're fine. 10% I have to adjust. In thyroid, it's 20%. Thyroid's harder. So 20% of the people I have to adjust. Here it is, there are muscles, little tiny muscles that are underneath the white part of the eye. I don't have to go through the eyelid. The white part of the eye is like my shirt, it's just a cover. I make a little hole, and the muscles are right there. I can hook them, cut them, and move them. And then there are little stitches that stick out. We tuck those away, and they dissolve if we don't need them. So this gives me a chance to take a look at you, and I get a second shot at it, to fine-tune a little bit if we have to. Now, sometimes the best decision we make is to do nothing and let the body deal with itself. And so sometimes we have to do it that way. So it gives us a really nice out to do that adjustable sutures. Some of the surgery we do is really old-style surgery. This is a procedure that we presented at our national meetings. It's hard to see, we just make a little hole in the muscle So somebody who's off by a little bit, we can fix. That's a 150-year-old technique that's sort of been lost for a while that we're able to use. We do worry about the blood supply in the eye. Sometimes we'll do a special test to find out that the blood supply is okay, because thyroid disease can choke the blood supply. I told you about the eyelid. Well, this is a patient, look at her eyelids, okay, being pulled back and retracted. We didn't operate on her eyelids. We only operated on her eyeballs. The eyeballs couldn't come up. So she was really fighting hard, lift them up, 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 and the eyelids were flying up. Because when you look up, your eyelid moves up to get out of the way. So she thought she was looking up, even though the eyes got stuck, and the eyelids were going flying high. When I released the inferior muscles, her eyelids were fine. She didn't need surgery. So you have to be very careful about the order we do this in. Now I want to tell you something else, and this is really important to me, is I get people who come to me from all over the country. And for some reason, the people who come from other places, I wasn't getting quite as good results, and it was really bothering me. And it took me a long time to figure this out, maybe because I had a blind spot about this. And the blind spot was they were getting their decompressions done differently. And the decompression that you're seeing by Dr. Cacao when he moves the eye back was trying to restore normal. Those eyes are pushed out really far like this. You can't move the muscles and get that to move well. So why are our results being better? Don Cacao is handing me patients with the eye back in the normal position, and now the muscles have range of motion. And there's no doubt that that makes me a better surgeon. Dang it, he makes me look better. I don't like that very much, but it's good to have a teammate who does that. So the better the decompression, the better the strabismus surgery. And talking to my colleagues around the country, we all agree. So the better the decompression, the more freedom of movement you give us, the better off we can be. So when that eye goes from here to back there, we have a much better choice. So just to sum up a couple of things, everybody's worried about radioactive iodine and what will happen to the eye findings, and it's fair. There's a statistical increase in eye findings when you give radioactive iodine. We find, and it's been shown, that if you give steroids, you can decrease the chance of that happening. We also found, both of us used steroids at the time of surgery because we think if the radioactive iodine is increasing the immune system by allowing the cells from the thyroid to spill out into the bloodstream and stimulating the immune system, well, then maybe eye surgery is doing the same thing. So we always use steroids at the time of orbital decompression and eye muscle surgery to try and decrease the chance of reactivation. We think in the future the eye disease is going to be from a pill and not surgery, but for now it's a surgical disease. And there are challenges that we don't know the answers to. So why do you get one eye? And it's hard to see here, but it's only one eye that's involved and not both. It's an autoimmune disease. Why is one eye involved? We don't know. Why, when, and how does the other eye get involved? Sometimes 20 years later. Well, how come immune therapy doesn't work that well? Who's going to get bad and who isn't going to get bad? Why is the inferior muscle, the bottom one, the most common? It's not gravity. We know that. What? Type 1 versus type 2, why does that occur? So we're still trying to get answers. Here's a woman who came in, her left eye was pointing down. We fixed her, and she came back years later, and her right eye started pointing down. This is not a flipped picture, you can see by her part. And her right eye started pointing down. Now we fixed her, but boy was she frustrated that years later, the other eye went. We don't know why. We're still trying to answer that. I hope next time we come and talk, we'll have better answers, because we're still trying to answer these questions. So our overall approach is still that 5-step plan. We think it really makes sense. And I want to emphasize this. You heard it from Dr. Cacao, you heard it from Dr. Levi on the video, and I want you to hear it from me. Cosmetic surgery is enhancing what is normal. Reconstructive surgery is restoring you to normal. So this is not cosmetic surgery. This is restorative, reconstructive surgery. And here, I can tell you these people who went from these pictures, look at that from the side. And in the office, sometimes we'll do this. This is the picture on the computer screen of what she looked like before, what she liked before. See the big smile? That's what you look like. So there's that woman looking straight down. And there she is, whoops. There she is afterwards. She came in, what? Last week. We said, Gail, we're talking at this meeting. And she said, I got to tell everybody something. So I want you to hear what she had to say.
Dramatically. I mean, I was a freak.
Can you hear?
People stared at me, and I couldn't stand to look in the mirror. And then I came to you within 7 months. I think we had it corrected, and people don't have any idea I had any problem. I was horrible. I couldn't get a driver's license. I really didn't go out much because I was, it was so ugly. I looked like a cyclops. My eyes stuck out so far, and it had gotten down so low that people thought there was, I was not a normal human being. And the surgeries were absolutely painless. That's what I just couldn't believe that. And I really didn't think you could ever get it to this. I thought I would have to settle for, okay, nothing more we can do, but, and go through life that way. And now I can wear eye makeup. I look totally normal. If anybody had this problem, I could not encourage them enough to do the surgeries. The easiest things in the world, really. And I'm a surgical nurse, and I did not believe that they could be done that easily and without any pain, and that they worked like that. I mean, eye surgery is so delicate. You just don't expect it to get back to that. It's remarkable.
Congratulations.
Thank you. I'm very happy for an old broad.
So, the point is that you have to aim high, otherwise you don't land high, right? And so, it's very powerful, I think, when you hear people talking about their experience that way. And she never thought she'd get back there, and she did. So let me end with just expectations. And Warren Buffett said this: the happiest people do not necessarily have the best things, but they appreciate the things they have. I think someone's been through this disease process and who's restored to somewhere anywhere near normal appreciates it. You heard her laughing about things that were terribly painful, because if you don't laugh, you cry. And I think that if we set our expectations properly, we can get people back to where they're functioning and looking normal. And that's really powerful. So with that, I'm going to tie up and ask Dr. Cow to come up so we can answer any questions that you may have. Thank you for your attention.